Hello, everyone. I'm Sarah Seibert. It's good to see you again. You all can follow me up. Mike stole my line of this being my favorite topic to discuss. I used to be the VA reporter, so I might be biased, but I'm excited to be joined today by Dr. Neil Evans, Acting Program Executive Director of the Department of Veterans Affairs Electronic Health Record Modernization Integration Office. How did I do saying all that?
Yeah, all right.
Richard Persinger, General Manager for Federal Civilian and APG at HP, and Rear Admiral Tracy Farrell, MHS Genesis Functional Champion for the Defense Health Agency and Principal Deputy of the Assistant Director for Healthcare Administration. Thank you all for joining me today. So we'll explore some of the current state of the federal electronic health record modernization, the challenges agencies are navigating, and how they're working to improve data sharing, clinical workflows, and patient outcomes. So to kick things off, Dr. Evans, can you set the scene for us? Provide an overview of this joint VA and DoD electronic health record, and how will this modern record transform how care is delivered?
Sure. Well, we're here in 2025, since you're asking me to set the stage for the current day, but I can't help but sort of reflect a little bit on where we are and where we've come from. I've been seeing patients I've been in VA for 24 years, seeing patients at the Washington, D.C. VA Medical Center, and we've had sort of backs and forth with regard to how do we share between the Department of Defense healthcare system and the VA healthcare system. Many of our patients are ultimately the same human beings who come from one healthcare system to the other. What does it look like for us to be aligned in how we're doing work and interoperable and delivering care? It's been a long journey, but I'm super excited about where we are today. And so I did bring some figures. Because right now, just when we talk about the federal EHR, what is the state of it? It is live at 138 parent military treatment facilities. That's a total of 3,638 DoD locations, not to steal your thunder with numbers, but anyway.
I love that you have our data.
I do have
that.
data.
Yeah, I love it.
6 VA medical centers, 26 associated VA clinics, 104 remote sites like telehealth, clinical resource hubs, call centers, 109 sites in the United States Coast Guard, 7 sites in the National Oceanic and Atmospheric Administration, taking care of more than 8.5 million unique patients, and currently with more than 207,000 end users. So over 200,000 people woke up today and said, let's go fire up the federal EHR. And it is one system. And I know that I've been on a lot of panels and talked about this for a long time, but I do think this is an example of where really across 4 cabinet agencies, the Department of Defense, Commerce, Homeland Security, and VA, we have come together to deliver a single common solution to support patients, where we're surrounding the patients who are receiving care. And we in VA DoD has fully deployed, Coast Guard is fully deployed, NOAA has fully deployed, VA has not. And so I think the state of where we are in the midst of a really significant acceleration with deployment. So at the moment, we're 200 days from our next go live, and 200 goes very quickly when you count them down. I have to count that every day, so I'm keeping that in my head. We're going live April 11th, 2025 at 4 sites in Michigan, Saginaw, Detroit, Ann Arbor, and Battle Creek. And then over the course of 2026, we will go live at a total of 13 sites, bringing us up to 19 medical centers and then all of the associated community clinics, with plans to finish deployment across the enterprise by 2031. So it's a really significant uptick. We're at a point in our deployment journey that DoD was at 5 years ago, when they were really on the upswing.
Yeah, that makes a lot of sense. It's very exciting. And Richard, I'd like to toss it over to you. When we talk about this one single interoperable record from the industry perspective, how are you working with federal industry partnerships to create solutions that are interoperable?
Yeah, so the first thing is our main job is to always to advance the technology, right, that the customer can use. I think in terms of EHRM, it's integrating and collaborating with the agencies so that, one, we're helping them to not only launch and deploy and support, but we're also not trying to bolt on technologies that later on become, problems in terms of interoperability. We were talking earlier before this session, and, I think it's important to think of the perspective of a patient or a clinician who's trying to use the system. And I don't know about anybody in the audience, but whenever I go to a doctor and they're putting in my information, inevitably they reach a screen where there's a function that doesn't make sense for what they're trying to do. And that always sticks with me. So from the industry perspective, we need to start to think that way first versus how can I sell you something and bolt it on.
Right, that makes sense. And Rear Admiral Farrell, we were talking, again, walking up the steps coming here. Your mission is do better, do it faster. So you have rolled out and deployed. What is next on your horizon?
Appreciate both my colleagues here. I think, is my mic not working?
It is. Good to hear
Oh,
you.
there it is. Okay. I appreciate the information. I think that ability to communicate from cradle to grave is significantly important. So what do we do to improve where we are today in achieving that? Of course, we have a strong partnership with the VA, but looking within our own internal utilization of the record, how do we now improve some of those workflows, compliance and adoptions, things that we can control internally, but really looking to see what technology is available today that we can integrate within the record to improve that end user experience, whether it's the patient or the provider. I continue to talk to my team about we believe we're doing the right thing for the right reasons at the right time. But we really need to include the conversations with our end users to make sure what we believe is occurring at the deck plate is truly occurring. So really our next milestones to improve the system, but then we're looking at the ambient listening, and I mean, really we're on the cusp of that. I'm really excited that by the first of the year we'll be able to deploy that to our clinicians. I lost you. Oh, maybe I need to just look straight ahead. I'll look straight ahead. Deploy that to our clinicians. I still get lost.
Thanks.
Okay. Technology. It's great when it works, right? So how do we integrate some of the technology, and how do we keep pace with the emerging technology? Government's really good at keeping pace with what's available. But that's where it comes in. We can do more, we can do better, but we can move faster. So ambient listening, automating coding, a lot of the automation and technology that's available, those are two that we are driving hard with Department of War. I have to change my vernaculars here. That's their priority. So that's our major milestones, is really improving the end user experience with automation. From the revenue cycle as well as the clinician's perspective.
I caught myself at the beginning. I said DOD too.
Yeah,
Yes, so Dr. Evans, I'll toss it back over to you. You outlined where you want to go, and you recently talked with one of our staff writers, Jordan, about a new waved deployment approach when you resume rollout. So could you tell us a bit more about what that looks like and how it enables interoperability?
Sure. When we started through our deployments, our original plan had been to go one medical center and its associated clinics at a time. We started in Spokane, Washington. We're live in Roseburg, Oregon, White City, Oregon, Walla Walla, Washington, Columbus, Ohio, North Chicago, Illinois. And each of those deployments was done with one leadership team, one medical center, and again, the associated clinics. And as we, frankly, collaborated with DoD during our reset, and said, as we get started back with deployments, what should we change about our approach to deployments? What did DoD learn after their original pause before they had the run to the finish line with regard to deployment, and what can we in VA learn to allow us to do this in a way that is better standardized across the enterprise and allows us to move faster? And one of the things that we realized was that a lot of the complexity that we were introducing in part of the deployment was, in the VA healthcare system, I think it's very much the same in the DoD as well, the system really functions as a deeply integrated healthcare system. And I know people hear this idea of when you've seen one VA, you've seen one VA. It's not, in fact, true in the sense that the sort of the expectations that we have for the quality of care that we're delivering and the experience that we're delivering to America's veterans are identical across the enterprise. And our commitment to that level of care and frankly, full interoperability of data, that is where we're circling our care around the veteran, is super important. And we share a ton of resources between sites, whether it's telehealth providers from our clinical resource providers, shared services through our telecritical care program with its main hubs in Minneapolis and Cincinnati, whether it's our call centers. There's a lot of resources, telegenomics, that are delivered at the enterprise level. And when we go live in a local market, and there's a period of time where a medical center that collaborates very closely with its neighboring medical center are on two different electronic health records, it introduces all kinds of complexity. Complexity with regard to training, that is, you have to train clinicians and staff for this kind of wonky interim workflow before everybody's on the federal EHR. It creates all kinds of complexity with regard to technical interfaces that have to be implemented that are only there just to stitch things together during this period of transition. And so there's a real opportunity, we realize, to say, let's start to think more in a market-based fashion. Let's look at medical centers that work together, that have a lot of resource sharing. I'll give you an example. In Ann Arbor, Michigan, where we're going to go live, 60% of patients who receive care every year at the Ann Arbor VA have a primary care provider at the Ann Arbor VA or one of its associated clinics, which means that 40% do not. So 40% of their clinical volume is coming as referral, often from Saginaw or Battle Creek or a sister medical center. And so by going live all at once as a cohort, we allow ourselves to build a sense of community around this deployment cycle and eliminate some of that sort of transition stress, where we're going to have people in sort of phased fashions on the different go live, and then really just driving faster and delivering each market at a time. So as we work through our schedule, we're going to be going live with 3 to 6 medical centers per wave based on their market alignment with their neighbors.
Right, that makes sense. And as we talk, you mentioned this earlier in your response, but about standardization and governance. So how are you standardizing governance, business processes, IT tools to ensure effective rollout and adoption? Richard, I'll start with you.
Well, in terms of standardization from the industry side, back to my earlier point about understanding what the agency is doing. And there are things that you don't even think of in terms of certifications that have to go along with the platforms that we're integrating to. And so making sure that if we offer something up as an industry partner, that we already know that we've certified with that platform and we're not going to create a hiccup when the implementation goes live.
Right.
So that upfront work is critical if you're going to help the agency deploy quickly and efficiently.
And Rear Admiral Farrell, I'd love to get your thoughts too.
No, thank you. I know Dr. Caban was here earlier and probably spoke to some of the work that he does on behalf of DHA with AI governance. So I think what we have evolved into at DHA is really that governance process internally that really reviews, prioritizes, and modernizes in a more strategic and very disciplined way. Really looking to what our federal partners can benefit from the partnership that we have, as well as our end users. So how do we put that governance and decision-making process in place to make the best choices, not only for our organization, but for the end user. So we have established a fairly new office with a digital integration and a governance process that brings in the relevant leaders within the organization so that they're part of the decision-making process, and the resourcing decisions are transparent across the organization. So I think we're fairly new in that, but it's developing and really maturing into something we can depend on, and it's replicable for any technology, IT solutions that we're exploring. So that's along with Dr. Gabon's AI governance and data governance that he's put in place.
Yeah, that's exciting. And he did speak on that. It's exciting to see where that's going. And Dr. Evans, is there anything that you would like to add?
Yeah, I think I could talk about standardization all day. It's it's something that gets me excited, which I don't know that normally clinicians don't get excited about the idea of standardization. But I think actually when we standardize the way we deliver healthcare and the way we use technology, particularly in a large system like the VA healthcare system, it is a path to better quality, and it's a path to better and faster innovation. But the hard work is to do that standardization on the front end. And the other piece of hard work is to define the word standardization, because we like to say the word standardization an awful lot. Yeah. And then everybody in the back of their mind somewhere has some meaning of what they think that actually means. Some define it from a technical perspective, that we have a standardized set of technologies, that we have a baseline. Some define it as how we interface to external systems. Some define it as to rigid configurations in the information system, the electronic health record. Some define it as workflows, like what is the sort of human workflow enabled by the electronic health record that happens in each of our facilities. And frankly, all of those matter. They all matter. And to try to boil that ocean all at once for a health system of our size and complexity, filled with 400,000 people with really strong opinions and 150,000 trainees from every medical school practically in the country and residency program coming in with their view of what right looks like, is not an easy task. But it's one that's absolutely necessary. And it's one that I think is this is a really unique opportunity for VA. Implementing a single enterprise electronic health record, we cannot maintain 50 different configurations of that, like 50 different versions of it in one instance, right? And so this has been an opportunity for us to really get more rigorous about decision-making around what is the baseline set of technologies that we're deploying? What is the menu that sites can choose from? What's on the menu and what's not on the menu? And then how do we build the structure by which we continue to Admiral Farrell's point, how do we build that structure to say, okay, that's great, that's what's on the menu today, but how do we continue to innovate and move that forward? And I think as we accelerate, it's giving us a real opportunity as we come to each site as part of their current state review to get things started, to have that meaningful conversation around what does it mean to get aligned to what is the VA standard for how we're going to deliver healthcare and what technologies are going to support that.
Yeah, and I'm going to stick with you for a follow-up. So we talked about this new approach as you resume rollout. Once you resume, what are some of the metrics you're going to be looking at to track progress, or what are next steps in that initial rollout phase?
I think, well, let's start with, we talked a little bit about the end user perspective. I mean, at the end of the day, right, we're deploying this system because our mission is to take care of veterans. So we care an awful lot about the veteran experience. We measure that on a regular basis. What is the veteran's experience of receiving health care? And it's not really, I don't really care what the underlying technology is. The question is, what's your experience about whether you received the health care that you were satisfied with? So we look at veterans' experience. We also look at end user experience. It is really important to engage with our users and understand and have a path by which we can source great ideas and get them implemented at the national level. We together, between the DoD and VA, we do an annual end user satisfaction survey. Because we like to overdo things a little bit in VA, we have decided to do it at least twice a year. We like to get the data a little bit more frequently to be able to course correct. We're looking at metrics with regard to return to system operations. So we have a whole set of metrics to say, as we go through this transition, how fast is the site returning to normal operations, normal productivity in the emergency department, normal productivity in primary care, revenue capture, et cetera. And then we look at the technical performance, right? As we continue to scale, I said 207,000 users. By the time we're done this, we have 400 to 500,000 users on the system. It's super important to pay attention to the performance, like the day-to-day, minute-to-minute performance from a technical perspective at the endpoint, right? Are people experiencing needless hangs, crashes, and lags, or are we delivering a system that is responsive and delivering for each of our users?
Right, and Rear Admiral Farrell, I'll throw it back to you. So we talked about moving faster, doing better. I've also heard doing more with less. So how are you navigating some of the challenges with revenue cycles and managing those business processes to ensure the EHR modernization is well positioned?
That's a challenging question, but a good question, because for a complex system that the VA and DOW runs, we're unlike any other healthcare system where you can just layer a business solution on top, right? So it's been truly challenging to capture really what that standard is in the healthcare arena for a business solution, and balancing what we have to capture as a defense agency, and the way we capture those elements, not just reimbursement. Right. I mean, that's critical in coding, but how do we capture those clinical skills that are being produced in the different arenas, the readiness that's being produced. So looking at a business solution that we can not necessarily just layer on top of the EHR, but one that gives us the data that we're looking to capture so that we can tell all of our senior leaders and honestly the Senate, the House, to justify those dollars that they give us. So the revenue cycle we've, over the last year and a half, have made, believe it, a year and a half, it sounds like a long time, but the amount of really analysis and gap identification that we've produced has really paid dividends. And I think over the next 6 months, we'll be able to capture all of those elements, not only that the civilian health systems capture as far as reimbursements, coding, all of the things that you need to run a successful business, but we'll also be able to capture those things that only we do in the defense, the Department of War, where we've got at the point of injury in the battlefield, we're capturing all that information from a business perspective, ingesting that into the health record so that you have it for the continuum of care throughout the life cycle of their health journey. So I think making sure that business solution looks at how we do business from the DOW and the VA's perspective to make sure that it captures everything we need to capture, not just reimbursement and the things that any other health system does, but really those critical elements to support the journey of their healthcare.
Right. And I'm going to combine the last two. I look down and I'm like, whoa, almost time for Q&A, so get ready. But DOW has talked about OCI, some acronyms here, moving over to the cloud. And Richard, I'd like to toss it over to you first to talk about some of the emerging technologies we are seeing or eyeing as we're looking to integrate new solutions into the modern EHR. So how is it making it easier? What solutions are you most excited about?
Well, there's my personal excitement, sorry about that, but we were talking about this earlier, right? There's so much new technology out there in terms of what can capture data about us as patients or as individuals. And it's how do you leverage that data and get that into an EHRM? And maybe it's not directly in, but it still needs to be leverageable data, right? What's that integration look like? The flip side of that, of course, is, I don't know about everybody else, but I mean, I've become consumed with these wearable devices and the data it captures about me. Now, I've managed to wean myself down to one. I was at 3 at one point. But you think about that. I mean, how much data is that capturing about myself every minute of the day? It's not conceivable that all of us capturing that amount of data. There isn't enough space in the cloud. There's not enough bandwidth to communicate that data. So trying to parse that out and figure out what's the most relevant, how to leverage it, connect it with an EHRM system so that a clinician can then use that, or AI can use that, right, to point out some things that maybe you can target. And instead of looking backward at a patient record, you can sort of predict things, if you will. That's what I'm most excited about. That's where I see the industry going, and that's where technology needs to lend a helping hand.
Yeah, definitely. And Rear Admiral Farrell, I mentioned OCI and that transition, but how is that enabling the adoption of, I know earlier you mentioned ambient listening, some of those innovations that are coming out?
No, thanks. Currently, we work in an environment that is not necessarily cloud-based, and we're migrating to the Oracle Cloud with our partners to make sure that the technology that we're adopting and the record that we are really consuming is in a protected environment and readily available faster. Can do more for us and can ingest all the technology that's coming. We work in a cloud, but the record is not. So that transition will take a little bit of time. Again, we can go faster. And I continue to say that, but how we get there is really important. How do we transition from the system we're on to that cloud, and what will that do for us? There's a new version of the EHR that's coming that would require cloud access and migration. But what kind of environment do we as DOW have to be in to keep our beneficiaries safe and secure? We talked about wearables. We have to be really disciplined in that area. We've investigated how that could inform, battlefield stress, all those things, but also how does those wearables inform our competitors of that as well. So making sure that cloud environment is truly secure, and the technology we're putting in there is something that we can continue to protect our nation with. I think that's really one of the things that we look at first and foremost for cyber and for the protection of our beneficiaries. So, but the cloud migration is a must for us to advance with all the technology. And so over the next 2 years in phases, we will move in that direction. But it's very complex because you don't just turn the switch. You've got to, and you'll find this at all of the devices, everything has to be worked into that process. So a lot of excitement there, but a lot of work has to be done, and we're excited about that.
And Dr. Evans, anything you'd like to add in terms of integrating emerging tech into a modern EHR?
Sure, but I'd love to get to questions and answers. I'll say this, right? Like, I think about things in 2 ways, right? We should always be thinking about the new. Yes, we need to migrate to the cloud. It's a big, complicated project that we're doing together. It is, all of this work has to be done with the understanding that every day there are hundreds of thousands of folks who are depending on us to deliver their healthcare. And so the reliability of the system is sacrosanct, right? Like if we're going to do a cloud migration, which is, by the way, a lift and shift, and then there's even more opportunity to optimize beyond that, we've got to do it in a very rigorous and careful way to make sure that we do not disrupt operations of the nation's largest healthcare systems. But that work is foundational work we need to do because it's what allows us to then continue. It is a piece of the roadmap forward to say, let's continue to innovate and deliver technologies. On this question of integration, though, I think it's a separate question. And I think that, to me, is a question of, it's important for us to understand this is like basics. It's What is the value that we're trying to deliver? What are the journeys that we are trying to support with the technology? And then how do we orchestrate technology solutions to deliver the outcomes that we expect? I mean, this is IT 101. And it's when you get into the mindset of the user and frankly the system and the value outcomes that we're looking to achieve, they are able to deliver that. It is one of the big value propositions of delivering a common commercial EHR is that we can, in the future, more easily orchestrate and deliver an integrated technological experience because we will be on the same baseline and we will have the opportunity to move forward faster in orchestrating whatever that looks like with next generation technology. So I'm excited about that. But for me, right now, number one focus is operations today at our 6 sites and preparation for the next 13 sites. Like that is the priority.
Yep, awesome. All right, well, I'll turn it over to you all. Does anyone have any questions? We have a microphone on this side of the room, and then there's one up here as well. So you're welcome to come on up and just introduce yourself. I see some movement.
Hi, how's it going? Dr. Evans, I know we worked together back in the day with the bringing mobile health. I know there was a question or comment brought up about patient-generated health data. We talk about a lot. I'm a veteran that gets care at Vision 8 today. I'm so proud to have access to applications like secure messaging and things so that when I go see a doctor today at VA, that doctor is working 12-hour shifts, only has 20 minutes to give me. So as a patient, I know that, and I have to prepare myself to ask the right questions right away. So my question, sir, while the focus is on 6 sites and you said 13 sites, can you shed a light, maybe at a high level from a strategy, from now until 2031? I look at myself, right, the 9/11 veterans, right, where we are quite tech savvy with mobile devices. Can you talk a little bit about future to come for next 6 years? How are we going to give more of these things like secure messaging or mobile health and other data in the hand of patients so veterans will be able to possibly leverage AI and others saying, hey, this is my record, this is what I understand. Prepare us from a veteran perspective so we can come prepared to ask doctors the right questions because the interaction between doctor and patient, it's always going to be between that 20 to 30 minutes. Thank you.
That's a great question. I think, look, in rolling out the EHR, I'm focused on rolling out the EHR. Now, writ large, do we care? I mean, I told you earlier that we care an awful lot, like an awful lot about the veteran experience. And I'm going to tell you that the best patient, the research shows, the best patient is an engaged patient. Like that is our job in healthcare. Our job is to support and care for those who have served and to help them live their best and healthiest lives, right? And so to your point around patient-generated health data, right? Like it should be the job of primary care providers to help us as patients to understand what do we do with all this data? What do I think about when my phone tells me I didn't sleep well last night? How do I put that into context, right? Those are the conversations, and frankly, that is what healthcare is, right? Like I've been in primary care for a long time. My job is to help folks understand and navigate their own symptoms, their own data, their own health journey, and to be their advisor. And there is zero question in my mind that patient-generated health data, whether it be device data, wearable data, app-based data, I don't care which, there's going to be a lot of innovation in that space, and that will be a part of healthcare conversations for years to come. And there will be too much complexity in that space for folks to understand it fully, and it's going to be part of the conversations we need to empower in the exam room. In addition, I believe that there's going to be prescribed digital therapeutics, right? Like I think sometimes prescribing an app can just be just as effective as a pharmaceutical in certain circumstances. And we need to figure out how to support that in a more seamless and meaningful way in our information systems.
Thank you.
This is another question for Dr. Evans. My name is Edward Gray, and I'm a reporter at NextGov. So during his confirmation hearing, Secretary Collins said that to get this effort back on track, part of the work that had to be undertaken was getting Oracle back, as the main focus, putting the onus back on Oracle, I believe he said. So how has the department worked on kind of getting Oracle back, kind of to take the lead on this project? I know, for example, the contract with Oracle was changed up a bit, so it's a 1-year contract now. And I'm just wondering how you have worked to make Oracle kind of take more of a lead role in this and kind of ensure that they're following through on their commitments.
Yeah, I mean, I think, look, we have a big task in front of us, and Oracle is a critical partner in that effort. And I think that's what the Secretary is getting at, right? If we're gonna deliver at the scale that we're committing to, we're all in. And that means both the government and our vendor partners who are delivering this, right? We've got to be focused on execution, execution, execution. And that's our commitment.
And just one follow-up. I know before the new administration that change management was a big issue when it came to deploying. Clinicians had some issues I'm sure they expressed. It seems like addressing, the clinician experience has been a big priority recently. I know Deputy Secretary Lawrence, it seems like, has been kind of on a tour of every facility that's going to have a rollout, kind of engaging with the clinicians and end users. So I'm just curious to know, how has VA kind of undertaken this process to engage more with clinicians? Because it seems like this has been a big part of your effort to kind of restart the rollouts of the EHR moving forward.
Yeah, absolutely. I mean, I think, look, when you add up the numbers of folks, I mean, I always want to think about the size of this project. Between our staff, 400,000-ish, plus 120 to 150,000 trainees per year that come through, you add up those numbers and you quickly get to above 500,000 people who all have to navigate this change. It's a different way of thinking, it's a different way of working. Every single one of them, we need to help shepherd them through this, right? So this is a very, I think sometimes it gets boiled down to being thought of as a technology project. It's really a people project. It is about change management. It is about what I'm going to call the adoption journey, right? Like, it's how do we help people through the whole journey to being able to use the new technology, to get excited about that. And I think a lot of that is keeping those lines of communication wide open. As you noted, the Deputy Secretary is going to every site that's going live on a regular basis and having conversations. He's in Cleveland right now, having conversations with the team in Cleveland, getting real-time feedback, what's going well, what's not going well, where do we need to intervene. And this is, this panel, I think, is called Managing EHR Implementation. At the core of what EHR implementation is, it's that level of engagement, right? It is a big change that we're walking through, and that type of engagement is the path to success.
Great, thank you so much.
So I want to ask a question about interoperability, if you don't mind. I know it's EHR implementation, but one of the main selling points for VA to adopt the MHS Genesis health record was that it could be interoperable with DoD and Coast Guard. What are the VA's plans now that, or what are the interoperability plans with the VA now that we're moving towards a more, a centralized system? Because earlier, Dr. Postek was talking about TEFCA and how it's being adopted across the country, but we don't really have any plans from the VA right now on its participation in TEFCA. Could y'all speak a little bit about what the future looks like for both departments?
Do you want to start?
Sure. I think our goals in working together is to ensure that the interoperability exists not only in the EHR, but any of the technology that we're looking to advance and integrate within the EHR. The gentleman that asked previously, I think we're in a very unique position to be the VA's test bed for some of the technology. We can learn from it and then make sure that we're sharing those experiences. We always make sure whatever tool we're integrating is communicated and discussed with the VA to make sure that we have an agreement that, hey, this is a technology we both want to pursue. It will be interoperable between the two organizations. So that governance between VA and DoD is clear. I mean, it's disciplined, and we have those discussions as we progress in technology, not only as they roll out the EHR, but as we continue to advance anything within the complete rollout in DOW, we share that with the VA, and I think that's one of the criteria we use up front. It must be interoperable, not only with the VA, but also with our operational units downrange. How do we get that interoperability across all those platforms?
Yeah, and so agree, and I'll take it a step further to tease apart the word interoperability there. First of all, I can't remember a time seeing patients in the last 15 years where I haven't had every piece of data from the Department of War that I need in order to see patients. Through the Joint Longitudinal Viewer, I can always see all DoD data. It's not always convenient. I got to do 5 extra clicks and open up the note and read it, and then I got to translate it in my brain and then dictate it back into my new note, but it's there. I have access to the data. When we move to a common record, that data that started at DOW will be first-class citizen right there as if it was VA data. I won't know the difference. That's a type of interoperability that allows us to use that data to drive clinical decision support. Suddenly that data is more meaningful because it is computable, discrete data. So that's one piece of interoperability. The second, which is I think the question you're asking, is how are we exchanging data with the community? A big part of the of what we were delivering here in the joint project has been not just the electronic health record, but our joint health information exchange. Because I brought figures, I'll read them too. The Joint Health Information Exchange is currently connected to over 104,000 non-VA providers of sites of care and 90% of US hospitals. So increasingly when I go, and this by the way is live regardless of whether you're using the federal EHR or Vista using JLV, I can see data from 90% of US hospitals. It's rare now that I can't find a note from the ER when a patient's seen there. We are participating with 3 exchange partners, eHealth Exchange, Commonwealth Health Alliance, and Care Quality. Just to give you a sense of the scale, in January of 2025, VA and DoD together were a single responder, VA and DoW, exchanged 361.3 million documents, and there were 18.5 million patient matches in January alone. So there is an awful lot of data sharing going on from an interoperability standpoint. We also fully support TEFCA and are part of those conversations and look forward to moving forward in that space.
Thank you for that. And I'm sorry, are over time, so I'll wrap it there. But I appreciate all of your questions and your perspectives. Thank you for the work that you're doing. And I look forward to catching you in a few months and seeing what the updates are then.